Can you hear me?
Yeah. How are you?
Hello. Good evening.
Good evening, dear.
How are you
Okay,
today?
your slides, can you share pot on the share screen, the green one?
Yes,
Yeah,
yes. 1 second.
very good. And
So,
please, you can open your video camera.
like that?
Yeah, this is the slides. It's very good.
Perfect. Let's see.
We cannot see you. Your cam?
How do I turn it on?
Yeah, very good.
Can you see me now? I don't know how to turn on my camera. There we go.
Okay.
There we go. There we
Yeah.
go. Wow.
Very good. How are you, dear friend, my Dr. Kjetil? Yeah,
Thank
Larsen. Yeah. Okay. I will at first introduce you for the attendees. First, this episode today is very interesting and a lot of informations with the best tutors in the pain research. I think we will enjoy today with this presentations with Dr. Kjetil Larsen. He is independent peer researcher and he is also a researcher at MSK Neurology. The topic today it will be about the common sense approach to low back pain, diagnosis and interventions, which is very interesting. A big title under this umbrella. I think a lot of DDs, differential diagnosis, a lot of perspectives, a lot of experience. I think all we enjoy with this tour. So the screen with you, dear Dr. Larsen. Yeah, you can start.
Thank you so much. But first of all, I'm actually not a physician.
Okay.
Regardless, this talk today, it will be about low back pain. We will talk about discogenic low back pain, radicular causes of back pain, and also muscular causes of low back pain. Now, the first segment is going to be about the red threads in the research. It has been said that we don't really know what causes low back pain. Well, a lot of research shows us that there are some red threads that we can follow to see the mechanism of pathology. So we will talk briefly about that. We will talk about basic examination today, some red flags, whether or not to order imaging, which is an interesting topic, I think, and whether or not we should choose a conservative or surgical approach to the case at hand. So let us get started. Research has shown with regards to this, we are now starting with discogenic low back pain and the pathomechanism of degenerative spine disease. Research shows us that, and we know if we read images, we know that virtually all disconations, they are directing posteriorly or posterolaterally. Research has shown that reduced sacral and lumbar angles are involved in the genesis of these herniations. And we know also that virtually all disconations in the lumbar area are in the L4, L5, or S1, L5, S1 area. Moreover, research has shown that the muscles that extend the spine rather than flex, actually those who extend the spine, they tend to atrophy in low back sufferers. And we can see this even in young patients, even teenagers. You can see multifidi and extensor atrophy if the problem is adequate. Now, research has shown very clearly that to get the disc to herniate posteriorly, we need spinal flexion. So this has been very well proven. Gallagher actually showed that with 22 degrees of flexion, the disc herniated 6 times faster than in a neutral loaded angle and 30 times faster at a 45-degree loading angle. So that shows that the disc pathology, it progresses much more rapidly if we are loading it at a certain angle. Is it a coincidence that most disconations happen in neutrally lordotic structures? We know that thoracic spinal disconations, for example, has about 1 of 1,000 in prevalence. So most disconations, actually 95 or more percent, happen in the low back or in the neck, neutrally lordotic spinal areas. We know that when we compress the front of the disc, the anterior part of the disc, this will force the nucleus posteriorly. And when this happens over and over a long period of time, not over 2 weeks, but over the course of many years, eventually the disc will protrude backwards due to a gradual delamination. Therefore, we will get, when we press on the front of the disc, we can get the bone compression will happen in the front, and actually the wound in the disc, it will happen in the back of the disc. And this is why often, even though the patient has a flexion problem, when they extend the spine, they will get pain when they go into extension because the wound is in the back of the disc. And the flexion mechanism to disconation has been very well proven, even in the pain science crowd, which are generally against the notion of biomechanical causes of pain. They also agree with this notion. Now, what about discogenic pain? Is discogenic pain a real problem? Nociception may occur prior to frank discopathy, simply to prevent discopathy. So that means that if you have an MRI, for example, and the MRI doesn't show any pathology, that doesn't mean that the disc is healthy. Quite contrary, the pain is there to help us to avoid damaging the disc. So just like if you put your hand on a stove and the stove is hot, you will get pain to make you remove your hand to avoid damaging your hand. The intervertebral discs are actually richly innervated. This means that even though the disc may not be damaged per se, they have a sensory input. So when you stress the disc, it can certainly generate pain. The discs are innervated predominantly through the ventral sympathetic chain. This is also known as a fight or flight system. This may explain why stress can exacerbate pain in low back patients. It's an amplifying factor. Another interesting fact is that, well, at least a notion is that Guimard, they found a strong correlation between a flexed posture and an introverted personality. And they also found an interesting association between extended postures and extroverted personalities. And this may give us an explanation, a possible explanation to why patients with anxiety or depression suffer more from spinogenic disorders than patients who don't. Edgar, he showed that the nerve endings actually penetrate deeper into the disc tissue when there is disc pathology. Therefore, there's actually real neurological changes that happen when the disc gets damaged. Discogenic pain, it tends to manifest as a deep central ache in the spinal column. So if you have a patient and you are considering whether or not this may be a discogenic case, well, the pain will generally occur in the column itself and generally in the low part of the spine. So for example, if you're bending forward, bending back, lateral flexion, the patient will state that they feel pain or tenderness in the column itself. Discogenic pain, it has been disputed, but in my impression, my experience, discogenic pain is a real phenomenon. Here we see a diagram that shows, let's see if I can remove this. We have a diagram here that shows the ventral chain. It also shows here how the dorsal root ganglion connects directly to the ventral sympathetic system. And therefore, when a disc is injured, we can actually get referred neuralgia, even though there's no frank root compression, just simply referred pain through the sympathetic system. And it's well known, for example, that once a real big disc herniation hits, even if there's no root compression, the pain may radiate into the stomach, into the whole pelvis, and there's no real explanation for that on the images. Well, this is my impression of why that can occur. As I said, discogenic pain without herniation, it has been controversial, but it is my impression that this is a real phenomenon, and I know that many others also share this view. With regards to stress, stress is usually an amplifying factor. We'll get back to that later. Modic changes. Modic tends to develop in the front of the spine, so the anterior aspects of the vertebra in the beginning. This fits well with the herniation mechanism because when we compress in the front, there's approximation of the bones, and there is in the anterior aspect, and there's a separation in the posterior aspect. This over time will cause a bone edema, as we see here in this slide, and of course herniations to the back. Over time, we will see a loss of disc height because the disc matter has been herniated many times and it's simply lost. Eventually, you will have bone against bone, and you will see rapid increases in modic changes, basically bone inflammatory disease. Sometimes, especially if the patient is refractory to all conservative treatment, this is also another controversial topic, but sometimes, especially if there is diffuse pain that radiates into the stomach, plexopathic pain, similar to plexopathic pain into the stomach, into the buttock, down the legs, and there's no MRI finding that explains these neuralgic referred symptoms, you may be dealing with spondylodiscitis or an infectious modic problem. In these cases, even though the blood work tends to be normal, they may respond to antibiotics. Posture in low back pain. This is another controversial topic. Many researchers have claimed that there's no correlation between pain, lumbar pain, and the posture. But if we look at the herniation mechanism, we see that flexion, over time at least, not immediately of course, but over time it causes disconnection. And we also see that the muscles of the extensor musculature, they atrophy. So a logical approach would be what kind of posture would diminish, would oppose those changes. And clearly, if flexion and extensor atrophy induces the disconnection, then the opposite, i.e. increasing lumbosacral extension and engaging the lumbosacral extensors in posture, that would cause a circumferential loading of the discs. It will increase muscular support in the spine. Another pro for partial changes, even if you may disagree that posture has an impact on low back pain, psychologists, they agree that a good body posture is important for good sense of self-worth, and therefore it should be implemented, in my opinion, even in non-organic, i.e. non-structural causes of low back pain, or psychogenic causes, if you will. Lumbopelvic alignment. So we will discuss now a couple of common measurements that are made in the lumbar spine, and I will discuss why. I will state my opinion at least of why they are often inaccurate. And if we have inaccurate measurements, then we can correct the patient's posture and they will still not get better or even get worse. So first of all, to have an appropriate correction, we need to know the pathomechanism. And it's a common notion that hyperextension causes low back pain, but then again, if hyperextension causes low back pain, then why do we see all these disc herniations going backwards? If hyperextension was a real legitimate problem, we would see a lot of anteriorly directed disc herniations, and we don't see that. Regardless, measuring the pelvic tilt by aligning the PSIS to ASI is the common correction, but this will actually place the patient in hypolordosis. I will show you why. Another common measurement is when measuring lumbar extension by making a vertical line from the T12 down towards the sacral base. And if the T12 is behind the sacral base, we say that it is lordotic. But actually, this does not at all take into account the sacral angle, and because so many disc herniations happen at the L5S1 segment, this is an important variable that must be taken into account. When you put the patient into ASIS-PSIS alignment, you will see that the patient's thighs will angle forwards. This is actually a hyperextension of the hip joints, and it stretches the iliopsoas in the posture. Moreover, to get into this position, you will have to disengage the lumbar erectors, and most patients will have to brace their glutes or brace their abs to get into that position. You will see that the buttock will point down rather than back and up. This is hypolordosis. It is not neutral. Lee, in 2012, they show that a pelvic incidence, so the sacral angle, so to say, of less than 45 degrees had 3 times higher prevalence of degenerative disc disease. This makes a lot of sense because we know that most disc herniations are in the proximity of the pelvis. So if the sacral angle is low, this will place more anterior shearing on the discs that are in the proximity of the pelvis and therefore increase the risk of posterior herniations and degenerative disease. It also shows that the sacrum or the sacral angle, the lumbosacral angle, is perhaps the most important variable or predictor for low back disc disease. And it also, as the sacral angle diminishes, the low back extensor muscle activity also decreases. Hence, the multifidi and erector tone reduction and even atrophy that we see in these patients. Now, if you look here, we can see actually this is a patient who has a low sacral angle. We see that the disc height is reduced, both L5, S1 and L4, L5. And we can see here that the pubic symphysis is anterior to the ASIS, but interestingly, if we look at the PSIS is still superior to the ASIS, even though the patient is clearly in what we would call a posterior pelvic tilt or a hypolordotic position. Once again, showing that this measurement is not reliable. Some clinicians, they state that we can have a greater, more reliable measurement by drawing a vertical line from the ASIS and down to the pubic symphysis. And I actually share this. I share this notion. I think that this is a good measurement. So I will show you that in a second. So Osar is a chiropractor in the US called Evan Osar, and he is more or less physiotherapist, I would say, than a chiropractor. But he states in his book, and it's a great book, Corrective Exercise Solution to Hip and Shoulder Dysfunction. He states that the best way to, the best representative measurement for pelvic neutrality, if you will, or good pelvic posture, lumbar pelvic posture, is a vertical ASIS versus pubic symphysis. In this case, we can see that the structures are, in this illustration, the structures are vertical. But if we go from the ASIS, PSIS measurement, it will look like it's hyperlordotic. But as I said, this is not hyperlordotic. This is actually neutral posture. And it is consistent with the Lee study that shows sacral angle less than 45 degrees has a much greater prevalence of degenerative disease. And it showed that, I think it was 60 degrees, sacral angle of 60 degrees of pelvic incidence that had a much lesser prevalence. Here is a typical patient who would be deemed hyperlordotic. Clearly, the patient has a huge arch in their back. Well, you can see that the pelvis is clearly forward and the back is hinging back. But if we look at the buttocks, we'll see that the buttock is pointing down and there's a crease under the buttock, which suggests that there's a low sacral angle. So what actually happens here is that when the pips comes forward, we get hip hyperextension. So we get predisposition for impingement syndromes in the hips. The chest comes back, so we get a hyperextension of the thoracolumbar junction. And then the patient will generally compensate for that by squeezing the glutes or the abs and hyperextending their knees. And this causes that chronic hypolordotic segment in the lower back, which is exactly where the disconnection occurs. How do you see this? Well, for most people, this can appear hyperlordotic. You really would have to look at the gluteal, where the glutes are pointing. And during examination, if you palpate the extensors, you will see that they're usually a very high tone, either in the glutes because they're clenching them, or in the abs. And the paraspinal extensors, they will appear very flaccid at the lower back upon palpation. The way to correct this, we're going to come back to that, but the way to correct this is basically to pull the pelvis gently back and teach the patient to stay there. So they will have to take responsibility of their posture rather than expecting someone to treat it for them. Anterior pelvic tilt, like I said, and if anterior pelvic tilt was a real common problem, then we would see an epidemic of anteriorly protruding disc herniations, and we simply don't see that. Most of the time, if the disc herniation is protruding anteriorly, the whole disc tends to be destroyed. So it's just kind of poking out to all directions. Now, is this really anterior pelvic tilt? You can see here that there is hyperextension of the thoracolumbar junction. We can also see that there is hip flexion. In my opinion, and this may sound strange, but in my opinion, the low back angle here looks pretty straight. So if the patient can get their chest up a little bit and extend the hip slightly, this will actually be a nice and straight back. Another interesting notion is that most patients with so-called anterior pelvic tilt, they tend to develop mid-back rather than low back problems. So this is not a very common presentation in my experience. I see this much more often. But now and then when you see this, they tend to have thoracolumbar junction symptoms rather than disc herniation at the low back. For patients who tend to flex at their lower spines, either because of chronic ab clenching or glute clenching, they will often develop this little edema or even a big patch of swelling superior to the spinous processes in the lower back. It can be at the L4 or L5S1 area. It's interesting that Stecco has showed, Langvin has shown, that the thickness of the fascial density here correlates with pain levels in most circumstances. So this patch down at the low back, this tends to be a manifestation of chronic flexion at the lower spine. And palpation tends to hurt in the same area. But not all low back patients will have this. Usually it will be chronic patients with chronic affliction. Sometimes you can have even chronic low back patients with disc herniations who don't have swelling, but generally they will have it in my experience. If the pain of the patient, so we always have to ask the patient, where's your pain? If the pain of the patient is not in the central spine, nor radiating, we can look for some common denominators or commonly affected structures. The quadratus lumborum muscles are a common cause of posterior flank pain. It will hurt with flexion, it will hurt with opposite contralateral bending. And if you squeeze your thumb into the muscle, the patient will scream if they have pathology here, if they have an injury here. What I usually do, I just ask the patient, where is your pain? They will point to the flank. I will squeeze my thumb into the flank and I will ask, is this the same pain that you've been suffering from? If they say yes, then I will strengthen the QL. If they say no, I will keep looking. Actually, there should be some more information here. Other common causes, of course, are, if you get to the SI joint, for example, SI joint is often misinterpreted as low back pain. SI joint problems can be a real SI joint. If so, the SI joint provocation tests, such as the thigh thrust, the femur, etc., they will be positive. It can also be cluneal neuralgia. If you have middle cluneal neuralgia, which will mimic the SI joint, it's usually a piriformis problem. Those are from the sacral plexus. If you have superior cluneal neuralgia, which will usually manifest as a mimic of gluteus medius pain, that actually those nerves come from the upper lumbar, so that's a psoas problem. So if the pain is over here, it tends to be a psoas pain-related problem. If the pain is in the SI joint and the SI joint tests are negative, it tends to be a middle cluneal neuralgia. It's a piriformis problem. Pain over here, pain upon pressure, usually a QL problem. And I also found that paraspinal muscle pain tends to not, in my experience, it tends not to be actual damage to the paraspinal muscles. It tends to be dorsal ramus pain referred from the psoas, because all of the lumbar plexus actually emerges through the psoas. This should have been a little better written down in the presentation here, but it is not. So we have already talked about the causes of discogenic low back pain. We have talked about the most common postural presentations. Now let's talk about radiculopathy and red flags. One of the most common things I do after I ask the patient where their pain is, and if the pain is either reminiscent of a radicular pain or central pain, is that I will examine their lower extremity myotomes. Significant weakness in a myotome, especially along with radiating pain upon flexion or extension, it tends to suggest radiculopathy. Radiculopathy can be benign, especially if it's a mild disc herniation, there's no severe root compression. It can also be more sinister if there's a significant root compression. In such a case, we will see great weakness of the affected myotome. Here we can see, this is actually like a Cauda-Equina syndrome. So here the whole central canal is affected. In such a case, the patient may have a sphincter dysfunction. So they may have urinary incontinence or on the backside. It may also be the other way around, that they are not able to defecate or urinate. That's a red flag and suggests imaging if you don't have imaging already. Usually along with weakness, but not always. Usually it comes along with weakness. The most common nerves that get affected, especially in younger people, is going to be, the dorsiflexors or the toe extensors, toe flexors. So the L5 and the S1 myotomes, those are the most common areas of affection in younger patients. In old degenerative spine disease, so let's say the patient is 60 years old or 70 years old, now you may see degenerative disease all the way up to the high lumbar aspect. So for example, hip adduction of adductor myotome weakness, very uncommon in a young patient, but you might see that now and then in a patient who is of older generation. Regardless, I always go through all of the myotomes and ask the patient if they have any problems with going to the bathroom. If there is a mild weakness, you have to look if it is discogenic or arthritogenic. We will get back to that, because disc herniations giving mild weakness and radiculopathy generally tends to respond well to conservative treatment, whereas root compression due to arthritis, well, now you have arthritis in the actual root outlet, and you cannot really treat that conservatively. You can maintain it maybe with a root block or analgesics, but you cannot treat it conservatively. So back to that. If the patient has improvement of radicular symptoms when they go into spinal flexion, but immediate worsening, or at least very rapid worsening of symptoms in lumbosacral extension, this generally will, at least in the lumbar spine, it will suggest arthritogenic root compression. That means that there's arthritis filling up the root outlet, compressing the root. The neuroforamina, they widen when you go into spinal flexion, but they narrow actually quite significantly when you go into extension. It is often underreported, especially in the lumbar spine, because it is harder to see root stenosis in the axial plane on MRI, but it's easier to see in the sagittal plane. It's often underreported. Another thing is that the MRI report may state that there's root compression, but it may not state the cause. And it's, as the clinician, it's very important to figure out whether or not there is arthritis compressing the root, which you cannot really treat conservatively, or if there's disc matter, and especially how big the disc matter is. If there's a small disc causing radiculopathy, generally that will suggest that the spinal canal is congenitally slender, and it's harder to get those problems to improve with conservative therapy, versus a big disc herniation. May sound more scary, but a big disc herniation tends to heal better with conservative treatment. Regardless, what I will do with these patients, I will do the myotome examination first in neutral posture. Then I will have them extend the spine for 1 or 2 minutes, and then I will redo the examination of the myotome immediately. And if they develop weakness in the myotome after extension, especially severe weakness, this suggests surgical intervention. We will get back to that. Another important notion here is that when you have arthritogenic foraminal stenosis, this will often not cause a myotome paresis, severe weakness, as we see in a disc herniation. In a big disc herniation, you will often see acute onset of severe weakness. The onset is much more insidious in arthritogenic root stenosis, and because the degree of compression varies on flexion extension angles, the patient will often not develop frank paresis. There will be variable degree, maybe grade 4 weakness, but then if you put them into extension long enough, you may cause severe weakness of the myotome. And I will have a little case study here eventually. It's actually here. This is a case study. It talks about this. This is a very interesting case, actually. Long-standing low back pain. The patient is 67 years old. She told me, I know my back. She told me it's not back related. I know my back. And she has been rendered to a wheelchair because she cannot walk due to horrendous pain in the right buttock and down the leg. I started reading her reports, and it said the MRI had shown like 4 levels of root stenosis. So that made me suspicious right off the bat. And it said foraminal root stenosis and lumbar foraminal root stenosis happens generally due to arthritis, not due to disc herniation. The patient had been very thoroughly examined at several hospitals, and it was deemed that this was not a surgical grade stenosis because she did not have paresis. But then we're back to the notion that in arthritogenic stenosis, we generally don't see paresis, okay? So she was able to walk on her heels and toes, so the L5 and S1 myotomes, so Lasse's and reverse Lasse's tests, they were negative / maybe borderline. And she was now under investigation for B12 deficiency, neuropathy, and polyneuropathy in a prominent Norwegian hospital. And she sought out a service for a second opinion. Now, I examined her myotomes and they were grade 4+. They were almost normal. She kept telling me, it's not my back, and I know my back. I told her I disagreed with her because I looked at her images, and the images showed, as you can see here, these are just a couple of screenshots, severe root compression in the foramina. And as I said, when you go into flexion, this space for the root, it will improve, and therefore the root will heal a little bit. Before it worsens a little bit, it will heal a little bit, and it goes back and forth like that. So what I did, I had her walk on her heels and toes. It was okay. Then I had her extend her spine, and she almost collapsed. She could not load her legs at all. So it caused almost immediate severe weakness of the quadriceps, of the dorsiflexors, and also of the calf. And of course, now she wasn't that convinced anymore that this was not low back related. Now, what happened in this case? What happened was that Allahu Akbar, Allah. All right. So what happened in this case was that this is actually a very treatable problem through something called foraminotomy. So they simply go in with endoscopic treatment and shave off the arthritis. The reason that she was not scheduled. The reason she was not scheduled. أشهد أن محمد. Should I wait or should I continue? Okay, I will continue. So the reason that she was not scheduled for surgery was the neurological exam did not show paresis or any significant weakness of the myotomes, and therefore the neurologist thought that this was not any significant root stenosis. However, the images clearly suggest otherwise, and as I said, when we placed her in extension, she could not walk at all. This was spinogenic, it is treatable, and she was now rendered to wheelchair for 2 years needlessly. Interestingly, also when I put her in extension, now the Lasse's test, both the typical Lasse's as well as the reverse Lasse's for the L3 and L4 roots, were both conspicuously positive. So paresis is not common in arthritis, and arthritis, it does not heal. It does not heal. When it's borderline, you can treat it with blocks, G6.
حي على الفلاح.
But when it is moderate or more, it requires surgery. You can do one short-term conservative treatment by simply reducing the lordosis. If you put them into flexion, although this will speed up the degenerative process, this will temporarily relieve the root compression, and it can be a temporary conservative intervention while the patient is awaiting surgery, for example. As I said, paresis is not common in arthritis. Lack of paresis does not mean that this patient is not a surgical candidate. There was a hand raised, I think, but I don't know how to answer that because I'm not so familiar with Zoom. Perhaps the host, Dr. Nagm, can you assist?
Yeah, sorry.
So there was someone who raised their hand. Should I continue now or should I answer that question first?
Any problem, doctor? Yeah, Larsen?
No, not at all. There was someone, it said that someone raised their hand.
Yeah, some problem in my computer. Yeah, sorry for that. Okay.
No problem. Okay, I will continue. Okay, diagnostic workup. So we got to ask, where is the pain? What kind of pain is it? And which movement exacerbates the pain? If the patient tells you that they have this horrible central spinal pain, it's much worse with spinal flexion or extension, but it doesn't radiate. It's probably discogenic pain. It's probably discogenic pain. It could also be facet joint related, but in my experience, generally discogenic pain. And they will respond positively to the postural corrections that I discussed. If you have radicular pain that worsens with spinal bending, it probably suggests a discogenic root compression. If you have radiculopathic pain that worsens with extension, why does it worsen with extension? Well, because generally we narrow the foramina when we go into extension, and that will warrant an MRI. We will talk about that soon. For spinogenicity, we will look at pelvic alignment, lumbosacral erector tone. Does this erector seem flaccid, hypotone, hypotrophied at the L4, L5, S1 segments? Very common. Is there presence of a supraspinous process edema? Is there a lot of pain when you palpate the spinous processes? This is actually dorsal ramus sensitivity and it's caused by the sensitive disc. It's not 100% sensitive or specific, of course, but generally, if you palpate the spinous processes and adjacently, you will find increased tenderness in the area that is affected. Myogenic causes, palpation. First of all, if the pain is central, it's usually spinogenic, not always, but usually. If the pain is peripheral, you can there's a greater likelihood that this may be myogenic. Palpation of the QL, psoas, erector spina muscles, how tender are they? And importantly, ask the patient questions. Does it reproduce the same pain that you're suffering from? If they say no, keep looking. If they say yes, you probably have it, and you can treat it by strengthening the affected muscle. I generally don't like to stretch or needle or massage them. I find that it always comes back. So the appropriate intervention, in my opinion, is to strengthen, gentle strengthening of the structure over time. It usually takes 3 to 6 months. Lassegue's and reverse Lassegue's test. The Lassegue's test is for the sacral roots, so the L5 and S1 roots generally. And the positive Lassegue's test suggests low lumbar radiculopathy. A positive reverse Lassegue's test suggests something with the femoral nerve. So that's going to be the L3, L4 nerves generally. And you can also actually do an abduction test. If there's a lot of pain in the groin upon abduction, that may suggest L3 radiculopathy, which is well, up obviously middle lumbar, mid to upper lumbar. That's more uncommon. It's more appropriate in elderly usually, or if you have a patient with very congenitally narrow root foramina, which happens now and then. Myotomy examination, of course. Was the examination positive? And if so, does the imaging explain the imaging and the rest of the examination? Does it explain the weakness? Now, should you order imaging? This is an important question. If you have severe weakness or myotomal paresis, especially if there's also other indicators of spinogenicity, I mean, you have to order some images to see what's going on. If there's any kind of sphincter incompetence, you order images. Don't wait, you order images. If the examination suggests, I would say, significant artritogenic stenosis, I prefer to order imaging. Why? Well, because you cannot really treat it conservatively. It's a good idea to see the images, see what it looks like, and then you take the next steps from there. Maybe you try root blocks for a couple of months or years. Maybe you have them flex their spines a little bit. Or if you schedule them for foraminotomy, which is a simple procedure with great results if the diagnostic workup was done properly. And of course, if there's been trauma, you want to rule out a fracture or something like that. Conservative intervention. Well, first of all, what was the answer to the diagnostic workup? Did we have a suspicion for spinogenic causes, for example? If so, you're gonna want to increase the lumbar lordosis, presuming that there's no arthritis. If there's arthritic radiculopathy, if you extend their spines, it will improve the disc, it will improve the muscle function and the disc health, but it will worsen the radiculopathy, and therefore it is contraindicated in those patients. But in most circumstances, in discogenic causes, you can increase the lumbosacral alignment in posture. You will palpate the low lumbosacral erectors, see that they are actually mildly to moderately active when the patient is standing and bending. And they have to be instructed to keep standing and walking and sitting. Well, especially standing and walking and bending like that. Sitting, it depends how much you sit and so on. The patient should not be bracing. Bracing is a stress response, really. This is not a topic, but this is where the psychosocial stuff really comes in, especially if the patient has a lot of diffuse pain. Or let's say if you're 12 years old and you have low back pain, that's not normal. Even if your posture is really bad, if you're overweight, it's not normal to have low back pain if you're 12. So now we're thinking, or at least suspecting, that there may be some psychosocial problem there, and usually it will manifest physically with bracing. So they're going to be bracing their stomachs, holding their breaths, bracing their glutes, and of course, stomach and glutes. Both of these structures, they will reduce the lumbosacral alignment and of course disengage the lumbosacral erectors, and therefore we will see atrophy of these structures on MRI even in teenagers who have been chronically affected. If the workup suggested a myogenic cause, as I said, you strengthen the affected muscle. If someone wants to find a specific exercise for the QLs or psoas or piriformis or whatever else, you can go to my YouTube channel and you will find specific exercises for all of these. And I generally recommend doing 1 to 2 sets until moderate fatigue once or twice per week. You don't need to train every day. They need to have a good posture every day, but you don't need to train and train and train and train every day. I don't agree with that. Not everyone may agree with me, of course, but that's my experience. The patient should learn to bend with proper hip hinging technique. Now, this may not be so important if you're treating someone who's not that active. But let's say you're dealing with someone who has low back pain when they're deadlifting or squatting, or athletes, or someone who has a very active lifestyle. It's very important that the patient is able to avoid ab bracing excessively and able to keep their low back erectors engaged when they're bending. You will often see that as the patient bends, especially the low back patient, when they bend, even though the low back extensors are palpably active when they're standing, the moment they're bent, they completely inhibit. So they just go flaccid. And this is a motor dysfunction that can be retrained if you focus on it. It's basically an awareness problem. I briefly discussed this. Dorsal and ramus neuralgias. This is a little diffuse, but these and this could possibly be placed under the psychosocial groups, if you will. But if you have a lot of, if the MRI is normal, there's not a lot of QL pain, and you have this horrible paraspinal pain that doesn't really fit with any, I mean, if you know that there's no rupture of the paraspinal muscles and still they have this horrible pain down the paraspinal segments, it tends to be dorsal ramus neuralgia, and it's a referred symptom from a psoas dysfunction. Sometimes, especially if the patient is very afflicted, when you palpate the psoas, you can actually induce the radiative pain. Or if you strengthen the psoas, you will see that they have more pain the day after, which also confirms the diagnosis. Okay, surgical intervention. Now, of course, if you suspect Cauda-Equina syndrome and you have proven it with images, or you have detection of myotomal paresis, of severe weakness of a myotome, now you may opt for surgical intervention to avoid permanent root deficit. If you strangulate, this is variable how much the root can handle before it's injured, but in some circumstances, if you strangle the root long enough, the root can get permanently injured, and you maybe get a permanent drop foot, for example, or permanent calf dysfunction. And this is very unfortunate. Foraminal stenosis is another problem, even if it's just a grade 4 weakness, but there is a chronic pain over a long period of time. Foraminotomy may be the best choice to go for here. It is a curative treatment if the diagnosis is correct. They go with the endoscope and they shave away the arthritis to open up the foramina. Great results, simple procedure. A lot of patients are scared of back surgery, but we really need to distinguish simple endoscopic procedures from, for example, a spinal fusion. And I'm generally very against lumbar spinal fusions. I feel that they often do not give pleasing results. And another problem with the spinal fusions is that after you get the fusion, if let's say the symptoms do not resolve, now you will get huge metal artifacts when you get another MRI. And those metal artifacts can often make it very difficult to see what's going on after the surgery. Even on CT scans, it can be difficult. So I'm not very liberal. I'm quite liberal with the foraminotomy. I'm not liberal with the fusions. In some circumstances of severe disc height reduction, so basically bone on bone, and you do feel that there's a spinogenic origin of the pain, one may choose to try a disc replacement. But this is not something that is done everywhere. If you choose not to get the disc replacement, eventually the bones, they will simply grow together. They will fuse if it has been going on long enough. I've heard 6 months to 3 years from bone to bone date. So 6 months to 3 years to get the fusion. And of course, once the bones fuse, the pain will be gone. But in the period while the fusion is not complete, you may still have bone and modic pain, so to say, bone edema pain, bone pain. Finally, if you're not sure, if you're not completely sure what's causing the patient's pain, avoid opting for surgery. You should be sure. You should be relatively sure, comparing the clinical examination to the images. If we get a great diagnosis, we can get great surgical outcomes. And this was the end of the seminar. So now I hope I haven't been talking too fast. I received a message before we started that has seen my videos and said that I talk too fast sometimes. So I hope it was understandable what I have been saying. And I'm happy to answer questions now, if there are any.
Yeah. It's too late. Okay, thank you, dear Larsen, for this amazing talk. As usual, I'm following him for a long period of time. He's one of the best researcher at these topics and a lot. He promised me, then get a presentation about the thoracic outlet syndrome and some perspectives. So I think he's dear dear kjetil Larsen, he's very tired, too late, a lot of work, I think. So I want to focus on some questions.
Go ahead. I'm happy to answer your questions.
Yeah, okay. First, in our exam, there is a big perspectives about different medical specialties that say the low back patients. So the physical therapist, he bought some assessment tools and
Yes.
holistic approach to assist this patient. The surgeon, either orthopedic or neurosurgeon, he look for this patients in another way.
Yes.
Also, the pain intervention say some another perspective. So I think your assessment tools is holistic one,
Yes.
very, very, very interesting to get which the patient is the pain, not always the main problem, other than that interfering with the function. So
Uh-huh.
in getting what is the more harmful for this precipitate the pain, I think it will be success to do any management and intervention. Yeah, agree with this. You hear me?
I didn't quite get, maybe I didn't understand your point, sir.
Oh, okay. I think the holistic vision
Yes?
for the low back pain is the more accurate to take the decision, even it is
Yes. Oh, for sure. Definitely. You need to do the examination properly. And we need to evaluate not just the level of function, but also the level of affliction of the patient. Because sometimes you will see, I had a patient right now, I wrote about it on Facebook. The patient had horrendous pain. She was in a wheelchair there due to the pain, but she did not have, the Lesaix test was inconclusive, and she did not have paresis of the cuff. But she was in a wheelchair, and the MRI showed clearly the cause of the pain. Should we then say, well, it's no surgery? 6 years of that patient's life has been destroyed. So yes, we need to evaluate everything, not just one part. I definitely agree with that.
Yeah. Again, in ordering the imaging, can you
Yes.
did you prefer at first the dynamic X-ray and the loaded X-ray, then MRI at last, or ordering three of this imaging for first visit of the patient?
That's a good question. I generally don't, because I don't know with your patient group, but I tend to find that instability, frank instability, spondylolisthesis, and especially a surgical grade spondylolisthesis, it's much less common than radiculopathy. And so with the X-rays, you cannot determine any radiculopathy. So I'm going to order the plain X-ray, the plain MRI, supine MRI, and take it from there. And if there's any suspicion, let's say you had a trauma, for example, maybe you order both, right? If you had trauma. But if the case is typical degenerative spine disease, I will go for the plain MRI. And if there's no indication there that suggests instability, I will generally not ask for a flexion extension X-ray. However, let's say you see the MRI and you have the grades of the listhesis. Let's say the grades are inconclusive, or let's say there is myotomal significant radiculopathy upon spinal flexion or extension, and the MRI doesn't explain it. Well, now we may get a suspicion for instability, dynamic instability. And now, of course, if we get the X-ray, we might see that during motion, the listhesis is much greater than what we see in supine position.
Yeah, great. Second questions, what about in acute low back pain, acute stage? Some surgeon advise the patient to wear a lumbosacral corset or support.
Yeah.
Rest. Research nowadays that support this or not?
Well, whether or not the research supports that, I am not sure. But what I would suggest in acute low back pain is, okay, is there or is there not radiculopathy? If there is radiculopathy, you have to do the myotome exam.
Yeah.
If the myotome exam is normal, I will do the myotome exam, even if they don't have a frank radiation, because sometimes, interestingly, you can have a huge disconation, root compression, deficit in neurological deficit, but no radiation. It's very peculiar. I had a case neck patient actually today with a similar presentation. So I will do the maritime examination. If it's normal and if they have no problem going to the bathroom, I will generally tell them go to rest. Go to rest and you will recover. Once you get better, we can start with conservative approach. Of course, if there is great neurological deficit, you will order imaging.
Great. I said from your different videos and following you, a lot of your patients that you can rely upon the MRI finds. So a lot, I think there is no correlation sometimes between the finds of MRI
Yeah.
and true complaints of the patient.
Yeah.
So I'm in my clinic. I said a lot of patients has L4, L5 disc herniation.
Yeah.
Mean in L3 dermatome. Yeah.
Well, yeah, I see what you're saying. If they have so sometimes this is a little off topic, but I find that, for example, if you have radiculopathy, if you have disc injury, this may cause segmental psoas atrophy. This is off to entrapment neuropathies, kind of more so than spinogenicity, but spinal disc injury can cause segmental psoas atrophy, QL atrophy, extensor atrophy. It's interesting to know that the entire lumbar plexus, it emerges through the psoas. And once you get segmental atrophy, you get fascial rigidity and you can get entrapment neuropathy. And let's say this can affect the obturator nerve, for example, which pierces the psoas as well. Personally, I don't do a lot of dermatome exams. I find that the dermatome exams often are misleading or inaccurate. If there is pain, I find that the S1 and the L5 tend to be more accurate. Maybe the L4, but generally I tend to do the myotome examination and take it from there. I'm not saying that you have to do the same. It's just my preference. If there is an entrapment neuropathy, we will see that in entrapments, the nerve pain will follow the nerve anatomy versus the dermatome. So if you have pain along the entire nerve anatomy, you might want to consider whether or not this might be either a primary or secondary nerve entrapment pathology. So for groin pain, for example, obturator nerve, pretty common. Obturator nerve, it pierces the psoas, it pierces the obturator externus. Strengthening those muscles would be my approach if I saw that in my clinic.
Yeah. Okay, I think I must to thank you a lot, dear friend Larsen, about this talk and this effort and this tiring you for this amazing talk. I need to promise us to again get another webinar, I think soon. So thank you again for your time and your effort and your presentation. Thank you.
Thank you so much for having me. I really appreciate it. If some other people have questions, I don't know how you usually do this. If some other people have questions, I will be happy to answer them.
I think I'm sorry there is at last questions, but okay.
It's up to you. It's up to you.
Yeah. There is a question from Javer. Can get information about proper physical examination in patients with low back pain?
Yeah, well, that was what this talk was about. So we rewatch the webinar.
Yeah. You need to repeat this webinar. I'm sharing it on the page. Thank you, dear. Hope safe time in this crisis, COVID. Hope also to visit us in Egypt and almost open this travel or airplane.
Right,
So
I would be very happy to visit.
bye, dear. Okay, bye.
Thank you so much for having me. Bye-bye.